Bienvenidos de nuevo a ARI23. Tenemos el gusto de presentaros en este caso ya la cuarta sesión de ARI, cuando la córnea se complica. ¿Qué hacemos en esos casos donde hay problemas en la córnea que son difíciles de resolver y el paciente tiene un problema crónico casi siempre sin solución clara? Vamos a dar la palabra primero a Marla Betual, que nos va a hacer una keynote muy importante sobre queratitis herpética y nos va a hacer una actualización sobre esta importante patología corneal. Adelante.
Dear colleagues, this is a very great pleasure to be with you today to speak about herpetic keratitis. But first of all, I would like to thank the organization committee of the Alicante Congress and particularly Dr. Alio. Here are my financial disclosures. So if we want to speak about herpetic keratitis, we have to keep in mind some numbers that matter. The first is the risk of recurrence, more than 60% over a 20 years follow-up period after the first episode, which most of the case appears after the age of 20. There are about 70,000 HK patients in Spain, and this is the first cause of infectious blindness in Western countries. Despite being unilateral, herpetic keratitis impacts quality of life as much as a bilaterally blinding disease like glaucoma or age-related macular disease. The virus gets into the cornea after an oral transmission from the oral pathway through the flux droplets. The virus is able to migrate from the oral mucosa to the trigeminal ganglia, where it can remain latent from the whole life, but in some cases, it can reactivate and then migrate again in the other direction to the cornea. Once in the cornea, there can be three mechanisms that are sometimes combined: the viral replication with the cytopathic effect, the inflammatory reaction, and the neurotrophic damage. And according to the three mechanisms, we will use several types of treatments. The epithelial keratitis can be recognized when we are able to see dendritic or geographic epithelial ulceration, and the fluorescent staining is able to diffuse under the edges of the ulcers. And there is most of the time a corneal hypoesthesia. In this case, the viral replication is like the maximum, while the inflammatory reaction is moderate. The confirmation can be obtained by PCR on the epithelial debridement or on tear samplings. The epithelial debridement is very important to treat these patients, and we will also give antivirals, either topically or systematically. Topical antivirals are in three forms in Europe: a solution, an ointment, or a gel. The gel is the most commonly used because there is a good balance between tolerance and efficacy. Alternatively, we can use systemic antivirals, and most of them valacyclovir 500 milligram 2 times a day for 7 days. If it is the first episode, we have to educate the patient about the risk of recurrences. Stromal keratitis can also occur without ulceration. In that case, there are corneal opacities variable in size, shape, and location. There is most of the time a stromal infiltrate without any corneal edema, but there can be already neovascularization with lipidic keratopathy and again hypo or anesthesia of the cornea. The viral replication is low, but the inflammatory reaction is very high, and the confirmation of the diagnosis can be challenging because there are few viruses in the tears or even in the aqueous. One specific form is archipelago keratitis with stromal opacities that goes from the limbus to the center of the cornea, and with a very important steroid dependence in most of cases. The treatment of stromal keratitis without ulceration is a combination between systemic antivirals and steroids. Most of the time, we will begin by oral valacyclovir, 0.5 or 1 gram 3 times a day, and we will give also some eye drops of steroids and or periocular injection that are started promptly. A very near feature is endothelial keratitis with endothelitis. The diagnosis is made on the presence of stromal edema plus underlying keratic precipitates, and there can be three types: deciform, diffuse, and linear. The linear one is the most severe because there is a risk of endothelial cell loss. The confirmation is made by the PCR on the aqueous tap. The treatment must be very forceful with a combination of high-dose systemic antivirals plus steroids. Systemic antivirals in that case are at least valacyclovir 1 gram 3 times a day or intravenous acyclovir, and steroids are given 1 or 2 days later, combination of topical and periocular injection of steroids. Stromal keratitis can be also with ulceration. In that case, there are corneal opacities that are also variable in size, shape, and location, but there are most of all necrotizing lesions in the center of these corneal opacities. To make the diagnosis, we can see that the light of the slit lamp cannot go through the opacity. There is a frequent, if not always, associated epitheliopathy, hence the name of keratitis with ulceration, with most of the time also a very important anesthesia of the cornea. The confirmation can be made by the PCR on the tears. In that case, there is a very important viral replication, but a low level of inflammatory reaction. So the treatment must be very forceful, especially on the side of the systemic antivirals part of the treatment. So we can use either oral valacyclovir 1 gram 3 times a day, or oral intravenous acyclovir, or even forscarnet in the more severe cases. This is combined with a regeneration and protection of the nerves that can be through the installation of 20% autologous serum or PAGF. Scleral lenses can be an option, or even tarsorraphy. In all cases, we should avoid the use of steroid as long as the necrosis is present. The differential diagnosis of stromal keratitis plus ulceration is the neurotrophic keratopathy. In that case, the diagnosis is made of on a long history of frequencies with the presence of a central or paracentral ulcer plus corneal anesthesia, and the staining is not diffusing beneath the edges of the ulcer. The treatment is a long-term treatment with first the withdrawal of all the toxic eye drops, the addition of lubricating eye drops, plus the fact to provide growth factors like autologous serum, PAGF, or even amniotic membrane transplantation. And in some case, we will think to corneal neurotization to improve the quality of the neurotrophic keratopathy. But in the real life, most of the time, there are combo keratitis. I mean, like in this patient, combination of endothelitis plus stromal keratitis, and in that case, there was also some level of neurotrophic ulcer. In that other patient, there was a beginning with dendritic keratitis that was responding well to topical antivirals, but in the following days, the patient developed an endothelitis that was treated with steroids plus antivirals. Once the acute episode is healed, we have to think about prevention. The prevention should be discussed for every patient with more than 3 epithelial cases of herpetic keratitis per year, or 2 stromal episodes of herpetic keratitis per year. The treatment must be at least 1 year long, and most of the time we use valacyclovir 500 milligram per day. The patients should be also educated to be treated with a preventive a regimen when he is exposed to a risk factor, especially surgery. If it fails, we have to think about the pathogenesis of this recurrence despite already preventive treatment. They can be replicative or immune recurrences. In the first case, we will increase the dosage of valacyclovir. In the second case, we will add long-term topical immunomodulation. And for this purpose, the cyclosporine, topical cyclosporine, or even tacrolimus is a good option, as shown by John Shepard some years ago. And the cyclosporine is able to reduce the frequency of herpetic recurrences together with moisturizing eye drops or punctal plugs, of course, in addition to antiviral treatments. The idea is to make all we can to avoid keratoplasty, because we know keratoplasty has a bad prognosis when it is consecutive to an herpetic keratopathy. But there is another side of the coin. This is antiviral resistance. The first antivirals have been developed 50 years ago, but for now, 10 years, it has been demonstrated that recurrence to antivirals can occur. The first rule when we are facing a suspicion of resistance to antivirals is to rule out any differential diagnosis, and for example, MAP dot and fingerprint dystrophy. But when we are sure the diagnosis is really an herpetic keratitis, we have to confirm the resistance by genotypic or phenotypic testing. In most cases, there is a mutation in a gene encoding thymidine kinase viral protein, and in few cases, this is a mutation. These are mutations in DNA polymerase viral protein. In the case of mutation in TK, we can use treatments that are independent of the TK pathways, like trifluridine solution or intravenous foscavir, but unfortunately, we cannot use this treatment on a long-term basis. So probably in the future, we will move to new oral antivirals, but the efficacy has not yet been evaluated. So we are in the obligation to use specific pharmacokinetic properties of the existing drugs, like topical ganciclovir, which is very efficient because of its high intracellular penetration, oral famciclovir, that is also very efficient thanks to its long bioavailability in the cell, and or the ganciclovir thanks to its high affinity for DNA polymerase. The take-home messages are to evaluate pathophysiological mechanisms for each patient, to customize the curative treatment as well as the preventive strategy, to avoid keratoplasty as much as possible, and to suspect resistance in patients with a long-standing disease plus replicative recurrences despite antiviral prophylaxis. I thank you very much for your attention, and I thank my team for all the work done.
Thank you very much. Thank you very much, Mark. Excellent keynote. And now Maria is going to present the next speaker.
Ahora nos va a hablar Jorge Arias del Barrio sobre reintervenciones en queratoplastia penetrante.
Hola, muy buenas. Vamos a ver cómo abordar una queratoplastia penetrante que nos ha fracasado. Hay que tener en cuenta que este hecho, el del fracaso endotelial tardío de una queratoplastia penetrante, es de las causas más frecuentes de retrasplante. Y en estos casos está ampliamente demostrado que el abordarlo mediante queratoplastia endotelial es muchísimo mejor que hacer una nueva penetrante, ya que tiene un riesgo de rechazo muy inferior, pero ya no solo es el riesgo de rechazo, es el riesgo de glaucoma, la recuperación visual y un mejor resultado refractivo. Es decir, si teníamos una queratoplastia que funcionaba y funcionaba bien, obviamente hay que hacer todo lo posible para recuperarla, y eso a día de hoy se hace con queratoplastia endotelial. Hay que tener en cuenta que el hacer una queratoplastia endotelial en estos casos es un poquito más difícil, tiene algunas peculiaridades con respecto a la queratoplastia endotelial convencional, pero bueno, con esas dificultades realmente es algo totalmente manejable y hay que hacer ese esfuerzo, puesto que el beneficio-riesgo con respecto a hacer una nueva penetrante es muy a favor, extremadamente a favor de la endotelial. Ahora del abordaje sería, pues tenemos una queratoplastia penetrante, o bien hacemos una nueva penetrante o hacemos una queratoplastia endotelial, y dentro de ellas podemos hacer una de SAEC o una de MEC, y de cada una de ellas pues podemos decidir quitar o no el endotelio receptor, el endotelio fracasado. ¿Por qué? Porque hay ya amplia literatura que demuestra que realmente no es estrictamente necesario hacer la desdematorexis, y el no hacerla, siempre y cuando esta capa esté intacta, pues no afecta negativamente al resultado ni a las complicaciones postoperatorias. Podemos decidir hacer una de SAEC, técnicamente mucho más sencillo, mucho más estandarizable, puesto que no difiere mucho de lo que es una de SAEC convencional. Simplemente tenemos que asegurarnos de hacer un muy buen centraje dentro del área del injerto previo para evitar los escalones entre el huésped y el receptor, puesto que el dejar el injerto de SAEC a través de esos escalones de la córnea entre la córnea dorante y receptora, pues se ha visto que es uno de los principales riesgos, junto con las cirugías de glaucoma, de los principales riesgos de desprendimiento del injerto. Por lo tanto, el tamaño del injerto debe ser igual o un poquito más pequeño que la penetrante previa, muy buen centrado, y por lo demás la técnica pues es prácticamente igual que una de SAEC convencional. Como decía, se puede elegir o no hacer la deshematogénesis según la preferencia de cada cirujano. Está muy demostrado que la de SAEC es muchísimo mejor que hacer una nueva penetrante. Fijaos en el riesgo acumulado de supervivencia a 5 años. En una de SAEC la probabilidad de que ese injerto sobreviva 5 años más tarde es del 86,4% contra el 51,3% de supervivencia de un nuevo injerto penetrante a los 5 años. Es verdad que hay cierto grado de desprendimiento, como 6%, como decía, sobre todo asociado a escalones entre el huésped y el receptor y cirugía de glaucoma previa, pero un 6% es totalmente asumible. Y como decía, se puede elegir o no hacer la DSMED, puesto que en DSAIC bajo penetrante se ha visto que la hacer la desematorrexis no afecta a la visión y tampoco afecta negativamente al riesgo de dislocación del injerto en el postoperatorio. En vez de hacer una DSAIC, podemos elegir hacer una DMEC. ¿Qué peculiaridades tiene la DMEC? Técnicamente es más difícil que la de SAEC en estos casos, sí que supone un mayor reto quirúrgico, pero bueno, totalmente asumible. Y lo que sí que se ha visto es que la DMEC contra la de SAEC en pacientes con penetrante previa, el resultado visual es mejor, el riesgo de rechazo es mejor, el riesgo de supervivencia, la probabilidad de supervivencia a 5 años es mejor, pero hay una mayor tasa de fracaso y derribable, mayor tasa de fracaso primario por complicación quirúrgica y derribable en el postoperatorio. Nosotros hace algunos años ya publicamos nuestra primera serie, que es la primera serie de DMEC bajo penetrante en pacientes sin haber hecho la desematorrexis, demostrando unos resultados equivalentes a los pacientes en los que se les hacía una DMEC bajo penetrante con desematorrexis. Nosotros abogamos por hacer siempre esta cirugía sin la desematorrexis, haciendo un injerto de DMEC un poquito más pequeño que la penetrante, entre 0,25 y 0,5 milímetros menor que la penetrante previa y siempre con SF6 al 20% para tener un mayor tiempo de burbuja. En estos casos, al igual que los de DSAIC, es crítico estudiar la anatomía de la córnea posterior mediante OCT, porque hay que ver si hay escalones, cómo son esos escalones, ya que el evitar los escalones entre la córnea receptora y la donante va a ser fundamental para disminuir en la medida de lo posible el riesgo de necesitar un rebabbling en el postoperatorio. Aquí tenéis un ejemplo pre-post DMEC bajo penetrante sin desematorrexis con un excelente resultado anatómico y visual. Y aquí tenéis otro caso acompañado también de OCT postoperatoria. Como veis, el no hacer la desematorrexis no afecta negativamente a la visión ni a la transparencia de la córnea, como veis aquí, que no hay ningún grado de haze. En la tasa de rebabbling en nuestra serie de casos era del 25%, es decir, es verdad que es superior al de una DMEC en córneas vírgenes, pero aún así es inferior a la tasa de rebabbling descrita en DMECs con desematorrexis en pacientes con queratoplastia penetrante previa. Por tanto, el hacer la DMEC sin desematorrexis en paciente con queratoplastia penetrante previa es totalmente realizable y es asumible, puesto que no genera una mayor tasa de complicaciones postoperatorias, ni mayor riesgo de fracaso, ni nada. Eso sí, es muy importante que esta capa, si se va a mantener y no se va a eliminar, es muy importante que esté intacta, es decir, que no presente gutas, que no presente cicatrización y que no presente el precipitado retrográfico. Es decir, si ha de mantenerse esta capa es porque está perfecta anatómicamente, simplemente con un endotelio ya fracasado, pero anatómicamente intacta. De lo contrario, habría que quitarla. Aquí tenéis un caso, una de las cirugías, y la principal ventaja de no hacer la desematorrexis es que hace la cirugía muchísimo más rápida. Hace la cirugía más rápida, mucho más sencilla y con menos riesgo, puesto que la desematorrexis en un paciente con queratoplastia penetrante previa es más difícil que una córnea virgen y es ahí donde viene el riesgo a la hora de hacer una desematorrexis traumática que deje restos de estroma descolgados o incluso restos de DSMED, que eso es lo que luego lleva al desprendimiento de la DMEC. Mientras que de lo contrario, si se evita ese paso, pues hace que la córnea posterior esté totalmente intacta, se evita ese paso, se acorta tiempo y además al evitar daños en la córnea posterior se evita cualquier riesgo o se disminuye el riesgo de rebabbling por dejar una córnea posterior perfecta. Y aquí, ¿qué pasa si fracasa? Es decir, ¿qué pasa si hemos hecho una DMEC bajo penetrante sin desematorrexis y luego el injerto nos fracasa? ¿Qué hacemos? Hay que quitar la DMEC y la DMEC previas. Podemos poner otra DMEC, pues aquí tenéis un caso que hice hace apenas 2 meses, donde era pues esta tesitura, paciente con DMEC bajo penetrante sin desematorrexis, que va muy bien, sube a 0,9, a los años hace un rechazo, baja la visión a 0,3 y hacemos una nueva DMEC, bajo de este MET, sin haber quitado nada y como veis una restauración anatómica perfecta, con una restauración tanto en topografía como en lámpara hendidura excelente calidad visual demostrada por aberrometría ocular y aquí como veis la OCT donde se ven de hecho las 3 capas la DSMET original de la penetrante, la primera DMEC y la segunda DMEC, sin afectar a la transparencia, ni a las aberraciones, ni al haze, ni a la calidad visual, puesto que este paciente alcanzó una visión de 0,9, igual a la que tenía después de la primera DMEC. Pero, como os decía, si ha fracasado y tenemos una DSMET afectada, como en este caso con abundante precipitados retroqueráticos, por supuesto, esto hay que hacerlo. Y si hay que hacerlo, la forma que se ha demostrado idónea es asistida por láser de efecto segundo, es la forma que ha demostrado la menor tasa de rebubbling. En vez de hacerlo manualmente, ayudado por efecto segundo, eso ha demostrado que claramente reduce la tasa de rebubbling y la hace menor a las técnicas de DMEC bajo penetrante con desdematorexis. Simplemente hay que hacer un CT de ese evento anterior, planificar bien los planos quirúrgicos, ver hasta dónde tiene que cortar el láser y con eso ya te asiste y te ayuda a la hora de la desdematorexis. Al simplificar este paso hace que sea más fácil y eso es lo que disminuye la tasa de rebubbling. Por tanto, el rebubbling no depende, el riesgo de desprendimiento de la DMEC no va a depender de que haya una DSMET o no, va a depender de que la córnea posterior esté intacta y que no haya restos y fibras de endotelio o de estroma descolgados afectando a la adherencia del injerto. Muchísimas gracias por vuestra atención.
Pues muchas gracias, Jorge. La verdad que es una charla interesantísima. And now Professor Alio is going to introduce our next speaker.
Now the next speaker is Viridiana Kokawa. She will talk about regenerative therapy of the corneal endothelium. Viridiana, you are the next. Thank you.
Good morning, everyone. Thank you very much for welcoming me here. I'm very happy to present the updates on regenerative therapy for the treatment of endothelial diseases, with a particular focus today on the pharmacomodulation. I have no conflict of interest to disclose. As you know, corneal transplantation represents the state-of-the-art therapy for corneal endothelial disease. Over the past decades, major progresses have been made, especially with the development of the endothelial keratoplasties, advances that improve the reproducibility and accessibility to the treatment, leading to increasing numbers of transplantations worldwide and decreasing the threshold for intervention at earlier disease stages. Unfortunately, the increase in transplantation activity aggravates the global donor tissue shortage. It has been estimated that there is only one donor cornea available for every 70 patients in need, and 12.7 million people require a corneal transplantation worldwide. That's why there is a growing interest in finding minimally invasive therapies to treat endothelial diseases that can overcome the drawbacks associated with corneal transplantation. Starting with cell therapy, the concept of transplantation of cultured endothelial cells was proposed in the 1970s. Techniques to achieve this have continuously developed over many years. This process requires several key steps, starting with evaluating donor corneal tissue, isolating the cells from the donor cornea, preserving and expanding the cells in an in vitro substrate suitable for transplantation. The challenges lie on the corneal endothelial cell characterization. Indeed, in order to obtain the validation of cell therapy, we have to show that the cells are not modified and are functional before being transplanted to the recipient through cell injection or on a tissue engineered carrier. The genetic modulation is another option that is currently explored for the treatment of inherited endothelial dystrophies such as Fuchs dystrophy, which is the leading indication of corneal transplantation in developed countries. The genome editing involves using molecular scissors such as programmable artificial nuclease to excise the target sites in the host genome so that the defective genes can be removed, replaced, or repaired in situ. However, there are concerns associated with gene editing, such as the risk of off-target editing and the associated harm. Finally, pharmacological therapies have been developed and are currently tested. They represent a great hope, aiming to provide the endpoint equivalent to transplantation or cell therapy without the risk of rejection, procedural complications, and the high financial and labor burden associated with cell-based therapy. Targeting the right pathway is the key point to an efficient pharmacomodulation of the corneal endothelial cells. Over the past 2 decades, major advances have been made in understanding the pathogenesis of the underlying corneal endothelial disease, especially the pathogenesis of Fuchs dystrophy, in which oxidative stress has been shown as the central actor in the disease progression, as well as mitochondrial dysfunction and abnormal cell adhesion and migration, leading to an increased level of cellular stress, senescence, and apoptosis. Several mechanisms of action can be targeted to modulate the corneal endothelial cells, such as the apoptosis, the oxidative stress, the cell migration, adhesion, or even the EMT, which is the cellular stress. For instance, the FGF1 analog, which targets the cell migration, has shown the potential to accelerate in vitro and ex vivo cornea wound healing, not only in normal corneas but also in Fuchs dystrophy corneas. Interestingly, the FGF1 analog also stimulates the ex vivo proliferation of the corneal endothelial cells in Fuchs corneas, leading to the regeneration of the corneal endothelial cell layer. Another interesting pharmacomodulation being explored is represented by the ROCK inhibitors, which target the cell migration, adhesion, and EMT. And they are among the most promising candidates for treating corneal endothelial diseases. The Rho-associated called protein kinase is part of the serine threonine family and acts as an effector of the Rho signaling pathway. The effects of ROCK activation are associated with a multitude of cellular events ranging from actin cytoskeleton organization, cellular adhesion, proliferation, cytokinesis modulation, and the induction of apoptosis. These effects play important roles in modulating the adhesion and migration of the corneal endothelial cells and are both significant components for corneal endothelial migration and proliferation. Several ROCK inhibitors have been developed to inhibit the ROCK pathway signaling cascade. The ROCK inhibitors have demonstrated promising results, especially when used following Desmet stripping only, the DSO, for the treatment of Fuchs dystrophy. The ROCK inhibitor also showed the potential to enhance the cornea clearance time and the corneal endothelial cell count compared to the DSO without the ROCK inhibitor supplementation. Additionally, the ROCK inhibitors have also been tested after central corneal freezing in a Fuchs patient, followed by the use of ROCKI for 7 days, showing a clear cornea and a stable visual acuity up to 12 years. The therapy is also currently tested alone for the management of Fuchs dystrophy. When compared to placebo, patients treated with ROCK inhibitors are significant thinner corneas and higher visual acuity at 3 months. However, long-term follow-up is needed to confirm those benefits. Since ROCK inhibitors have been used for a longer period of time compared to more recent molecules, we are also able to analyze their side effects, the most frequent being the conjunctival hyperemia. However, cases of reticular corneal epithelial edema have also been described. This fully resolved in all cases upon cessation of the ROCKI. Another interesting molecule is the sirolimus. The sirolimus is also known as rapamycin and targets the mTOR pathway. The mTOR is a protein kinase that is a key signaling kinase that regulates a wide range of cellular functions such as cell growth, metabolism, and autophagy. Previous studies demonstrated that mTOR inhibition with rapamycin increased the survival of endothelial cells in culture derived from patients with Fuchs dystrophy by suppressing the TGF-beta signaling mediating apoptosis in Fuchs cell models. A phase 2 multicenter study is currently underway to evaluate the efficacy and safety of sirolimus in patients with Fuchs dystrophy. As we saw earlier, the oxidative stress is the main contributor to the slowly degeneration of the corneal endothelial cells in Fuchs dystrophy. Specifically, a defect in NRF2 signaling has been shown to cause increased corneal endothelial cell susceptibility to apoptosis in Fuchs dystrophy. NRF2 is a nuclear transcription factor that activates the antioxidant response element and generates a coordinated upregulation of antioxidant defense in response to cellular stress. The molecule sulforaphane is an RF2 agonist targeting cytoprotection by reducing the oxidative stress through phosphorylation and activation of NRF2. This transcription factor promotes the expression of antioxidant stress proteins and has been shown to decrease the corneal endothelial cell apoptosis in vitro. As you can see, several pharmacological agents targeting different pathways are currently being explored and tested worldwide, with a high interest in ROCK inhibitors. However, rigorous testing is essential to ensure both safety and efficacy of these treatments before they can be approved for widespread use. I hope this overview has provided you with a better understanding of the exciting developments in regenerative therapies for corneal endothelial diseases. Increasing our knowledge in this field offers new hope for overcoming the shortage of corneal tissues, and hopefully this will happen very soon. Thank you very much for your attention. I'm open for the questions.
Thank you very much, Viridiana. It's been a fantastic talk. And now Maria Gesa will introduce the next speaker.
It's a pleasure for me to introduce Professor Vincenzo Sarnicola from Grosseto, who is going to talk about the management of broken descendant membrane in complex cases.
Hi, good morning. I'm very happy to be here today speaking about this not very rare complication of DALK. In this paper, we published our result over 1,443 eyes in 15 years, and we observed 119 descendant membrane ruptures. That means 8.2%. In the post-op, we observed that 100 ruptures resulted completely repaired following the rules that we will speak in the next slide. But in 19 cases, the patient developed a double anterior chamber. In 13 cases, just making a bad observation of head position instructions, the double chambers resulted repaired. But in 4 cases, we should replace sutures, and in 2 cases, we had to cut the recipient bed to solve the disparity between donor and recipient. This is a typical peripheric ruptures that when we are cutting the stroma in the periphery, we can cut descemet as well. To fix these ruptures, we should follow the rules you can see on the left side of these slides. So we should complete the stromectomy, that in this case was already completed. Don't put air in anterior chamber because you can enlarge, in this case of ruptures, the ruptures. Suture the donor first and then air in anterior chamber. And you can see that following a correct position of the head in the post-op, the ruptures result fixed the day after. Head position, as you can see, is very important and can be uncomfortable for the inferior ruptures. One difficult situation is when the disparity between donor and recipient is developed in a manual DALK. And we can have 2 different situations, one where the recipient is steeper than donor, or when the recipient bed is flatter than donor. For example, this is a keratoglobus where when we were debulking the cornea, we perforated in 2 sheets of the tissue. To better understand, let's follow the schema. You have a disparity of the donor related to the recipient bed. You can see here, when we suture the donor to the recipient, we can develop some waves inside to the eye that can determine an untreatable double chamber. How can we fix this terrible double chamber? The surgical procedures we have suggested in literature is a full thickness total circular cut of the recipient bed. What I mean? I mean that we should combine a donor allograft for DALK with a self-endothelium as a graft, as a self-graft. Let's see the surgery. We are preparing the self-endothelium as a dissect graft, and then we glue the DALK allograft with the self-endothelium, as you can see here in the video. And let's prepare this amazing graft that can be sutured to the recipient bed. And you can see here the post-op, 1 day post-op, and 40 days post-op, and look the difference from the pre-op and post-op. The opposite situation is when the recipient bed is flatter than donor. As you can see in the schema, it's almost impossible to fix this rupture. Here is the situation when the patients come in our clinic, and this is the situation after 5 months of therapy. So we should make clear this cornea, and we have to do a large only DALK, large stromectomy, and layer by layer delamination. Let's see the surgery. So we did a 9mm incision with the bulkhead tissue, and going layer by layer, we perforate. So we prepared the donor and we sutured the donor. But look what happened after 9 days. The patient developed an untreatable double chamber with the recipient bed tight and flatter related to the donor graft. If in a case like this we only put air in anterior chamber, even if it's a very big bubble in anterior chamber, the disparity cannot be fixed. So we should move to surgical correction of the disparity. And the surgery that we suggest is subtotal circular full thickness cut in order to transform the recipient bed in a large tongue that can be reattached to the donor graft, putting air in anterior chamber, because now the recipient bed is flexible. Here is the surgery, so we removed some stitches, and with the scissors we made this subtotal circular cut of the recipient bed, and at the end we put the air in anterior chamber. You can see here the 60-day post-op follow-up, and this is 1 year post-op. So look, we started from this situation, and finally with the correct therapy and correct surgery, we arrived to this situation, fixing this terrible eye. So which is take-home messages to fix ruptures? Please consider the type of ruptures related to surgical anatomy. Take care about fixed donor-recipient disparity of curvature, use interrupted sutures, obtain an homogeneous residual bed, take care about post-op head positioning, and pupil dilation to prevent pupillary block if you let the patient with air in anterior chamber. I want to invite all of you to next SIGSO meeting that this year will be in Grosseto, my city. A lot of international speakers are reaching us, and call for paper, poster, video, and courses is open until November 20. Thank you.
Thank you very much, Professor Sarnicola, for such an interesting lecture. And now Professor Alio is going to introduce our next speaker.
Next speaker is Leila Lengol, and she's going to talk about the surgical treatment of neurotrophic keratitis. Leah, you have the time now.
Thank you for the opportunity to present this exciting topic. In this talk, we will discuss the principles of corneal neurotization, describe the surgical techniques, outcomes, and current challenges. We're all familiar with neurotrophic keratopathy, which is a devastating ocular condition. Corneal sensation is measured by Cauchy-Bonnet aesthesiometry, where a nylon monofilament is used to test the degree of corneal sensation loss. As we know, there are multiple available temporizing therapies, but none address the loss of corneal innervation. So in corneal neurotization, we are addressing the issue of loss of corneal sensation by transferring a expandable, less important sensory nerve to the cornea, allowing for appropriate reinnervation of the ocular surface. The principles lie in Wallerian degeneration, which allow for axonal regeneration through Schwann cell guidance towards the denervated target. The growth occurs at approximately 1 millimeter per day, and this procedure can be done either by a direct transfer of the donor nerve or indirect transfer using a nerve autograft or allograft as a conduit to guide the axons towards the cornea. This is an operation that was first described by Dr. Julia Terzis with contralateral transfers of the supraorbital and supratrochlear nerves. This was published in 2008 in Plastic and Reconstructive Surgery Journal, and the authors reported an excellent outcome at average follow-up of 16 years, with 6 patients achieving restored corneal sensation and improved visual acuity and ocular surface, as well as corneal sensation. This shows a schematic of the process that occurs at the ocular surface. As you can see, the popularity of corneal neurotization has increased, and from 2008 to 2012, there are 138 articles. So since the publication of the original article by Julia Terzis, and more than 75% of articles were published really in the past 4 to 5 years. So really anyone with decreased corneal sensation and irreversible loss of corneal innervation is a good candidate. We also want to make sure that the patient has an intact donor nerve, sensory donor nerve, which is most commonly supraorbital, supratrochlear nerves, but could be other ones such as infraorbital or great auricular nerves. Certainly patients who are very sick, bleeding, diathesis, or chemotherapy, malignancies, conjunctival scarring, severe conjunctival scarring aren't good candidates. This was my first patient in 2013, and I have since performed over 60 cases. And this was a patient I performed using a similar technique described by Julia Terzis, with excellent outcome and restoration of corneal sensation and corneal clarity. However, there are a number of problems with this approach, and luckily, essentially 5 years later, after the original publication by Dr. Julia Terzis, a minimally invasive technique was published by the surgeons from the University of Toronto, a hospital for sick kids, led by Dr. Borchel and Asim Ali, and they published the use of nerve autografts as interposition nerve grafts coapted to the supratrochlear nerves. This is a schematic showing the technique. This is a end-to-end supraorbital nerve coaptation, but the principle is the same. This shows my technique, which is similar, using nerve allograft instead of autograft. But essentially, this is an end-to-end coaptation with a supraorbital nerve which has been transected. Amniotic membrane is used to wrap the coaptation, and then the nerve graft is tunneled to the ocular surface. Epineurium is open, and the fascicles are inset around the cornea. This is a patient postoperatively 3 months. A similar technique can be used with an infraorbital nerve, and a window, epinural window is created, and the nerve graft is essentially sutured to that epinural window in end-to-side fashion, and then the fascicles are inset around the cornea. can see the conjunctiva is used to cover these fascicles. Further described another minimally invasive technique utilizing direct transfer of the donor nerves through a minimally invasive approach. And you can see this is one of my patients that I performed this operation on. And this uses an upper eyelid crease incision through which we're able to dissect the supraorbital nerve in this case. You can also do it the supratrochlear nerve. This nerve is essentially tunneled to the ocular surface as shown here. For longer length, an endoscopic approach can be used through that same incision, and approximately 8 centimeters of the nerve can be harvested. You can see these are my patients who've had this approach just through an lid crease or subbrow incision. We described the outcomes of patients who've had various techniques. Now, these are all my patients, so 29 patients, 28 eyes, and you can see the corneal sensation stabilizes at approximately 12 months. Minimal complications. There were 2 treatment failures and very few problems with these patients. This is one of the patients who had a concurrent corneal transplant. This is his corneal button showing no sensory nerves within the cornea. And this is him 12 months with in vivo confocal microscopy of this new cornea showing nerve regeneration. This patient underwent corneal neurotization at the same time as his corneal transplant due to descemetocele that had to be addressed urgently with a corneal transplantation. These are some of the other patients. So you can see improvement in scarring at 6 months. This is another patient. You see healed epi defect and improvement in corneal clarity and neovascularization. I've shown you this patient, another patient with improved NV and as well as improved ocular surface. This patient finally had a successful corneal transplant after undergoing corneal neurotization. This is him 24 months after corneal transplantation, maintaining a clear corneal transplant. This is another patient who had idiopathic neurotrophic keratopathy, an 8-year-old young man who underwent direct neurotization using supraorbital nerve. This is 3 years after surgery. I had one neuroma that formed, which was successfully resected, and the patient preserved his corneal sensation. So there are several challenges in the corneal neurotization world, and one of them is referrals. A lot of cornea specialists and comprehensive ophthalmologists are not familiar with the procedure. They deem it very invasive. There's aggressive marketing by pharmaceutical companies pushing the medication options rather than definitive surgical therapy, and also lack of understanding of the procedure. Reimbursement is also an issue, at least in the United States, and certainly not understanding the best timing for surgery, the optimal surgical techniques, best timing for supportive therapy, either before, after, during the operation, and understanding of when can subsequent ocular surgery, such as corneal transplant, can be safely performed. I want to thank the crew who helped me make this research happen and allow me to perform all these operations with significant assistance. So in summary, I'd like to state that corneal neurotization is an effective, safe, and really the only definitive treatment options for this devastating condition. I believe that early surgery is important to prevent complications. Health of the donor nerve is more important than the technique choice if the surgery is performed well, and more education, studies, and reimbursement optimization are needed. Thank you very much. This is my contact information if anyone needs to get in touch with me. Thank you.
Thank you very much, Ilya. It was an excellent presentation of something that is, at this moment, debatable and a very important new technique. Now we have a panel of experts that will be in the debate. The debate will be conducted by Jose Well. Jose, hello. Okay.
Hello again.
You are now leading the discussion, which is extremely interesting because all these techniques are remarkable, and this is, in my opinion, the front line of corneal surgery at this moment. So go ahead with the debate.
Okay. Jorge, let's move on. Unfortunately, we have only 10 minutes, so let's try to be as quick as possible. So the first question, following I take care about your microphones because there is a sound. But anyway, the first talk by Mark, and Mark is still here. So 2 quick questions, Mark. In those cases where you nicely show that you have a stromal lesion, stromal keratitis with a central ulcer where steroids should not be used, and this is very important because it's the opposite when you do not have an ulcer. Do you recommend to use topical antibiotics to prevent overinfection, or you think that they are not indicated? And the second one is that, which is your first option for all of us when you suspect there is resistance to the standard antidiabetic drugs?
Okay, so for the first question, I usually do not use antibiotics in top of other treatment when there is an ulceration of the epithelium of the cornea in the case of herpes, because I have almost never seen any super infection by any bacteria. And I remember a sentence by Joseph Collin, who always says there is no bacteria on top of viruses, and I like this sentence. So if I am very, very, if I want to be very secure, I would use only antiseptics, which are much less epitheliotoxic. The problem with the antibiotics is that they are very toxic for the epithelium, so you won't help the regeneration of the epithelium with antibiotics. And to answer the second question, when you are facing a suspicion of resistance, the first thing is to just remember that it could not be an herpetic disease. So for me, this is the first question, because most of the time when people are addressed, are referred to me for a suspicion of resistance. In at least, I would say 50% of cases, this is not an herpetic disease. So then if I really believe this is an herpetic disease, I will first increase the dosage of the regimen, of the antiviral regimen, because most of the resistance are only partial. So if you increase the dosage, you will go through the resistance. The real resistance are very, very rare. It's not very common in everyday clinical practice. And at the end, if it doesn't work, then I will try to harvest the virus with all the methods I can use. For example, a Schirmer strip to get the tears, or an aqueous tap to get the aqueous humor. And then I send the sample to the virologist who will do a genetic analysis and to confirm or not that there is a genetic resistant.
Okay.
Is it
Thanks.
clear?
Yes, useful. If there is any comment from any of the debate experts, just use the microphone. I move to the second talk from Jorge Leon.
If I may, just one fast question to Mark. You mentioned that we should try to avoid corneal transplantation in this case, and I agree as a rule, but of course you have the pressure of the patient sometimes looking for a restoration of vision. And I remember that the, let's say, traditional wisdom was saying that if we have cases which has no recurrences over X number of months or years, we could. So what would be your rule for this?
Yeah, of course, we should avoid as much as possible, but in some cases, this is mandatory to try to increase the visual acuity of the patient. So I would suggest not to perform a corneal graft before 1 year of complete silencing of the disease, even if it is under treatment. And of course, if the graft is made, it should be made under high dosage of antivirals before the surgery, at least 2 to 3 days, increase the dosage, and at least as long as the steroids are given after the surgery. So if, for example, if this is a PK, it could be for 1 year. In case of DMEC, it could be a little bit less. But as long as the triggering factor is ongoing, keep the maximal dosage. And in case this is a real hepatic disease at the base of the indication, I wouldn't stop the antivirals for before several months or several years after the graft.
Okay, thank you.
I presume that we all agree in that as long as the endothelium is healthy, this is possibly one of the examples where DALC would be the best option without doubts. No?
Yeah.
Okay, the next was Jorge Leon, and I would like to ask him and also to hear some comments from Nuno, who has also some strong experience on this topic. Which are your standard treatment, Jorge, for those cases where you do EK in both modalities, the psych or the MEC, on the top of a full thickness keratoplasty? Which is your standard treatment for the following months?
Okay, so to be honest, I follow the same regimen than in regular DMEC. So if it is the first time I do a DMEC under a PK and has been a PK that has been healthy for many years, I do it as a regular DMEC. So I start with a prednisolone every couple of hours for the first couple of weeks. Then I taper 2 every 4 hours, and then I continue tapering for the first year. But I keep on long-term steroids once a day or every other day for long-term.
Perfect. Do you agree, Nuno, that you have reviewed not only?
I would like to complement this discussion by commenting on the case that Jorge described of the DMEC performed under the PK without decimetorexis. I think that in these particular cases where you have a rejection episode after the DMEC, that you should consider removing the graft, because you have the antigenic load inside. So probably these cases are cases where you should remove the previous graft. I think this is something we should consider. But the standard prophylaxis, I agree with Jorge, with the exception that I think long-term steroids should be performed, even if it's a soft steroid once daily or every 48 hours.
Yeah, I see your point, Nuno, and actually makes sense. But the thing is that reality later, we don't have real evidence about what is best, because you can argue that is absolutely valid, and actually I agree with it. But on the other hand, you could think that the cells are dead, and not only dead, but you are going to sandwich them and isolate them with a new graft. So they are going to be in a new environment where those antigens are going to be almost disappeared or isolated. So makes sense what you said, but the reality is that we don't know. And it's true that it's controversial, this case I did. I was curious to know if it worked, and it did. But of course, it's only one case. So it's only a curiosity right now.
Viridiana, are you still there?
Yes, I'm here.
Okay. Nice options, but I think that we all, and you particularly, would agree that unfortunately today we cannot predict which are the best candidates for DSO, either with or without any stimulating factor. So don't you think that we would or we should work on that to either by genetic characterization or by other means to be able in the near future to distinguish which are those who will better receive this kind of treatment in front of the more standard transplantation techniques?
Yeah, so when I did this talk, I actually tried to make the overview, and you understand that right now there are still a lot of pieces missing to the puzzle, especially in Fuchs dystrophy. So we are trying, right, the ROCK inhibitor and other pharmacomodulators, but we really don't know what would be the effect, or even the pushing the cells in the wrong direction. Because I try to show you that there are a lot of pathways, but when you activate one, then you can activate all the other ones, and especially the apoptotic one. So I would say, if I look at the future, I think there will be options, and probably we might use several pharmacomodulators, but we will also we can also develop more the cell therapy. However, the cell therapy represents a lot of cost for the society. So I think that's a nice idea to have like another option, a cheaper option for the patient and for the society. For the genetic modulation, I think there is still a long way until we will be able to modulate the genes. So I would say, if I had to, guess, I would say both pharmacomodulator and cell therapy for the next 10 years.
Thank you, Viridiana. Unfortunately, we're running out of time, but I want Tony. He is probably one of the most experienced surgeons in our country doing deep anterior lamellar, and not being able to contact Enzo. Could you respond to the point that in the case of a rupture, independently if it is small or medium or large, but that you're gonna use tamponade for
Just say I'm connected.
Excuse me, Enzo, I did not see you in the list. Excuse me. Well, then you vote.
No problem.
Enzo, then Enzo and Tony, both. I think, Enzo, that you mentioned that your best option to prevent pupillary block is dilate the pupil. Some others, as me, prefers to always do a peripheral iridectomy because I am not always sure if this patient will particularly dilate properly or not. I was planning to ask you, when do you decide to do peripheral iridectomy, and to know the opinion of Tony Zavala, a very experienced DALC surgeon. So Enzo, you start first, yeah, and then Tony.
So, we don't have any problem in the pupillary block if we dilate the pupil. I put atropine at the end of surgery because the blockage of the pupil is related to the air that can close a small pupil. But if the pupil is well dilated, you cannot have any pupillary block because the bubble of air is smaller than pupil when it's well dilated. And we don't have to forget that we are making surgery in a patient that mostly of the time is aphakic. When you go to do iridectomy, if you do iridectomy from outside, that you take a small piece of pupil, it can bleeding, but you can even touch the capsula, and these patients are very young, you can have a cataract. So I really don't see any reason to do a iridectomy. Just dilate the pupil and you will not have any pupillary block.
Thanks, Enzo. We need to close. Tony, do you agree with Dr. Sarnicola?
I agree. We dilate the patient at the end of the surgery. We don't use gas. We only use air. We make sure that the air is mobile, but we use very little air, and then we position the patient, basically.
Okay. Then thank you very much, you all. I very much like your new glasses, Tony. And thanks. And we need to move, because if not, Jorge will crush us.
Don't you
Thank
like
you so much for the confidence. Bye.
Don't you like my glasses?
No, not so much. Not so much.
Ciao.
Ciao.
Ciao. Ciao.
Okay, thank you for this very nice session, and we'll see you next year. The session is closed. Thank you.